Hi, very good morning. So it's been almost a week. So we'll have some text-based questions at this session, right? So I've shared the questions yesterday in our Google group. I hope you have seen the questions and you have answered them. So we'll have a discussion pertaining to these questions now, right? Okay. Before proceeding, a very good morning all of you. Hi, Suresh, Sure Engineer Abhishek, Nature Lover, Prithvi, Nayab, hi. A very good morning. Hope you're all doing fine. So how is your preparation going on? Hi Farheen. Farheen, you drop a mail at 2 a.m. or 3 a.m. and you wake up early in the morning. How is it possible? Do you sleep, Farheen? Hi Shilpa. A very good morning. Okay, fine. So we'll proceed with our MCQs discussion, right? So in the process, we'll add up some key points pertaining to these questions. So coming to the first question, the process of transfer of information from RNA to proteins is called mutation, translation, transcription, conjugation. So what is the right answer? So as we know, a mutation is nothing but permanent alteration of nucleotide sequence of genome affecting DNA, isn't it? So let me just make a note here. So mutation affecting a DNA. So permanent alteration of the nucleotide sequence, isn't it? Yeah. Yes, Abhishek, good. So I'm sure you're all familiar with this concept because you might have been come across the same in your +1 and +2, isn't it? So mutation is permanent alteration in the DNA sequence or nucleotide sequence of your DNA, whereas translation is, what is transcription and what is translation? Soumya, good. Transcription. Farheen says transcription. Anyways, before going into that, what is conjugation? So conjugation, we have different types, depending upon the context. For example, if I say conjugation in biochemistry or biotransformation, as we have discussed, it is nothing but a phase 2 reaction. We have phase 1 and phase 2 reactions. Phase 1 reactions, we have oxidation, reduction, hydrolysis kind of reactions in your liver, in xenobiotics. And phase 2, we have this conjugation. So gluconeogenesis reaction, acetylation reactions, etc. Ultimately converting various compounds into polar molecules so that they can be excreted, isn't it? Whereas conjugation in bacteriology, where you come across this 6 pili, transfer of genetic material. So conjugation is a process of that enables genetic transfer, isn't it? So we have different meanings depending upon the context. But what is transcription? So transcription is nothing but from the DNA carrying the message to the RNA to tell you in a simplified and broad sense, isn't it? But translation is nothing but actual synthesis of proteins from these messenger RNAs, right? So carrying the message from your DNA ultimately via RNA to form the proteins, that is nothing but translation. There is a very minor difference, but these are broad changes that we observe in the process of protein synthesis. So proteins are nothing but their messages which are being given by a specific nucleotide sequence of your DNA. So transcription is a process in which a gene's DNA sequence is copied, that is transcribed to make an RNA molecule. And the enzyme which plays an important role in this this is RNA polymerase. Whereas translation is nothing but from this RNA, actual formation of proteins is called as translation, isn't it? Yeah, good. So the process of transfer of information from the RNA to the proteins is called as? Now give me the right answer. Isn't it? So in brief, the terms. It's translation. Right answer is translation. That's what we have been discussing, right? So transcription is carrying the message or formation of RNA from your DNA with the help of RNA polymerase. But actual formation of proteins from these RNA is nothing but a translation. Just refer your basics once again. I'm sure you will understand the concept again, right? So this is an overview, right? Yeah. Now, I hope it's clear. Now let's move on to the next question. So the right answer is option B, translation. Next question, which of them is a multi-enzyme complex? Pyruvate dehydrogenase, succinate dehydrogenase, enolase, none of the above. So which among these is a multi-enzyme complex? Yes, sure, engineer, as you rightly said, translation proteins produced by translating information of DNA using mRNA. Good. Yes, Abhishek. Regarding conjugation pertaining to bacteriology, right? Transfer of genetic material by cell villi through cell-to-cell contact. Good. Okay, now, so which of them is a multi-enzyme complex? So pyruvate dehydrogenase, succinate dehydrogenase, enolase, none of the above. Yes, Soumya, is there succinate dehydrogenase? Yes, anyone else? Okay. So multi-enzyme complex, a protein containing more than one catalytic site. right? So pyruvate dehydrogenase for heme, Prithvi, good. Hi Deepthi, good morning. Yes. So multi-enzyme complex is an enzyme which contains more than one active site, one catalytic site, or more than one catalytic function. And pyruvate dehydrogenase is an enzyme which converts pyruvate to acetyl-CoA, if you remember the glycolysis, anaerobic respiration, right? So pyruvate dehydrogenase converts pyruvate to acetyl-CoA through decarboxylation reaction. So there is release of carbon dioxide in the process, right? Yeah. Yes, Rish, it's option A. So pyruvate dehydrogenase is a multi-enzyme complex, right? I'll also give you some details pertaining to this enzyme. You can just make a note. Okay? Pyruvate dehydrogenase converts pyruvate to acetyl-CoA through decarboxylation reaction, right? Yeah. And cofactors which play a role include NAD+. Okay, right. Also, please make a note, pyruvate dehydrogenase, it's considered to be a multi-enzyme complex because it contains multiples of 3 different enzymes. So it contains 3 different enzymes in multiple numbers, and these 3 different enzymes include the first one. I hope you can see if I write in blue. Yeah. Clear? Do you want me to increase the size of the letters or is it fine? Yeah, the first one is lipoamide reductase transacetylase dihydrolipoid. Dihydrolipoid dehydrogenase. And pyruvate decarboxylase. So if they can ask you, like all of the following are the components of pyruvate dehydrogenase, except, so you can go ahead with this, right? So pyruvate dehydrogenase decarboxylase, right? So lipoamide reductase transacetylase dihydrolipoid dehydrogenase and pyruvate decarboxylase. So all these 3 are the components of this multi-enzyme complex, and as I mentioned, multi-enzyme complex has more than one catalytic function, right? So pyruvate dehydrogenase, it enables the conversion or catalyzes the conversion of pyruvate to acetyl-CoA through decarboxylation, right? And it contains 3 different enzymes: lipoamide reductase transacetylase, dihydrolipoid dehydrogenase, and pyruvate decarboxylase, right? Yes, I'll increase the size, sure. And also you can increase the quality of your video if possible, right? Yeah. And that's possible when you're connected to Wi-Fi. So this is in brief about pyruvate dehydrogenase. Okay. Now let's move on to the next question. The enzyme phosphofructokinase is strongly activated by cyclic AMP, adenosine triphosphate, citrate, fructose 2,6-bisphosphate. So the enzyme phosphofructokinase is strongly activated by. So for every enzyme we have certain activators and inhibitors. If you go through your literature, alongside every enzyme they'll be mentioning few activators and inhibitors also. Yes, Shilpa. I'm sorry, right. Fructose 2,6-bisphosphate. Okay, Shivaranjani is adenosine triphosphate. I know, if you remember, phosphofructokinase, it's an important regulatory enzyme in glycolysis. ATP is formed through this reaction, isn't it? Wherever you have this kinase, that's one way of remembering. You will have conversion of ADP to ATP, right? Energy production. Yes. So phosphofructokinase is regulated by certain inhibitors as well as activators. Yeah. Let me just mention them here. So ATP, citrate and H+ ions. So these are the inhibitors, whereas the activators include the substrate, that is fructose 2,6-bisphosphate. So the substrate itself acts as an activator, and ADP, AMP as well as inorganic phosphate. Inorganic phosphate or PI. So these are the activators of phosphofructokinase. So phosphofructokinase is an important regulatory enzyme in glycolysis. Make a note of that point. And this enzyme is inhibited by ATP, citrate and H+ ions, whereas it is activated by fructose 2,6-bisphosphate, bisphosphonate, ADP, AMP and inorganic phosphate. So we've already discussed the same in our E-classes also, right? You can just go through the video. So option D is the right answer. Next, in molecular cloning, blue-white screening is used to screen for recombinant vectors, to detect gene mutations, to identify desired chromosomal DNA inserts in plasmid vectors, or to detect the host DNA inside. So what is this blue-white screening? And also, I forgot to mention, if you have observed your soft copy, given the structure of this multi-enzyme complex, pyruvate dehydrogenase, right? So that is just for an understanding, right? You can go through the image illustration. And also, for this question, blue-white screening, I have given you one image, which is nothing but the image of a lysogenic broth, LG agar plate. Okay, we'll go through what this blue-white screening is about. So Shilpa Shivaranjani says option A, Farkin option B. Okay, so this blue-white screening is used to screen recombinant vectors but desired chromosomal DNA inserts in the plasmid vectors. So recombinant DNA. So we use this blue-white screening. In fact, we see those microorganisms which take up these vectors with this recombinant DNA, they appear white, and those which do not incorporate the desired DNA sequence into the genome appear blue, right? So this blue-white screening is mainly used to identify desired chromosomal DNA inserts in plasmid vectors. So first of all, we have this concept of molecular cloning. So the question is, in molecular cloning, how do you or what do you use blue-white screening for? So it's simple. Molecular cloning refers to the procedure of identifying the desired DNA sequence and obtaining multiple copies of it. So that's your cloning, isn't it? Only the desired sequence of DNA of interest is obtained and then multiple copies are made, cloned. So cloning of DNA fragment essentially involves few steps like fragmentation, ligation, transfection, and screening. So molecular cloning and all will not go into the details, but yes, the blue-white screen is a screening technique that allows for rapid and convenient detection of recombinant bacteria in vector-based molecular cloning experiments. So DNA of interest is ligated to a vector, that is a carrier. The vector is then inserted into a competent host cell via transformation, which are then grown in presence of an X-gel or agar medium. Cells transformed with vectors, this is very important. Cells or microbes transformed with vectors containing recombinant DNA will produce white colonies, whereas cells transformed with non-recombinant plasmids, that is only the vector without the desired DNA, grow into blue colonies. So that's the image which you are seeing in your soft copy now. This method of screening is usually preferred using a suitable bacterial strain, but even fungi, yeast can also be used for the same purpose, right? So this blue-white screening is a method of molecular cloning. So molecular cloning is nothing but identification of desired DNA sequence and then trying to amplify it to a number of copies. So molecular cloning as such is a separate entity in genetics, and this blue-white screen in particular is used for identifying recombinant DNA or desired chromosomal DNA that has been inserted into plasmid vectors, right? So based on a visual appearance, you can see which organisms have imbibed this recombinant DNA, which organisms haven't really taken up this recombinant DNA, because those which take up or incorporate these recombinant DNA appear to be white, the others appear to be in blue color, right? So I hope it's clear. So in molecular cloning, blue-white screening is used to identify the desired chromosomal DNA inserts in plasmid vectors. Okay. Yeah. Yes, we'll move on to the next question. So the major sites of gluconeogenesis are liver and kidney, brain, skeletal muscle, heart muscle. So these four options. What are the major sites of gluconeogenesis? New formation of glucose from different sources altogether. Gluconeo. Yes. So it's a standard question you might have seen while going through your literature. Anyways, so gluconeogenesis is nothing but non-carbohydrate sources giving rise to or from which glucose is being formed. So gluconeo, neo means new altogether. So the conversion of amino acids, lactates, glycerol into glucose takes place mainly in liver and kidney, isn't it? So very little gluconeogenesis takes place in brain, skeletal and heart muscle, and this gluconeogenesis happens in cytosol, although some precursors are produced in mitochondria. So the main site of formation of this glucose in the process of gluconeogenesis is cytosol. Takes place mainly in liver and some extent in the kidney matrix, about 1/10 of liver capacity, right? Yeah. Gluconeogenesis is absent in muscle, brain, and adipose tissues because of lack of which enzyme? So this already I think we discussed previously also. Hi Vineet, Shubham, a very good morning. Try answering the question. In the meantime, I'll add up some points pertaining to the previous question, right? So that at the end of the session, I can take a pic and share it in our Google group. So as I said, gluconeogenesis. Mainly takes place in liver and kidney, and the site of gluconeogenesis is cytosol, and gluconeogenesis is absent in muscle, brain, or adipose tissues. Due to lack of, yes, Prithvi, good, glucose 6 phosphatase. Yes, right. So the right answer is option A. Major sites of gluconeogenesis, liver and kidney. Now let's move on to the next question. Incorrect statement is: long-standing hypertension leads to left ventricular hypertrophy. Long-standing hypertension leads to right ventricular hypertrophy. Pulmonary hypertension leads to right ventricular hypertrophy. Coarctation of aorta leads to systemic hypertension. So which of the following is a wrong statement? And those who are coming or attending to our live session for the first time, we have shared the soft copy of these questions in our Google group, right? You can drop a mail at proctorbedentist@gmail.com if you want to join, so that you can access the material pertaining to live sessions which we keep on sharing, and also various updates from our academy. So coarctation of aorta, option D. It's also nothing but narrowing of aorta, right? Also called as aortic narrowing. So, which of the following statement is incorrect? Hi Preeti, a very good morning. Yes, so long-standing hypertension increases cardiac overload. As a result, it promotes left ventricular hypertrophy because left ventricle pumps your blood into your systemic circulation, right? And whatever connections you have, like your right ventricle, supplies blood via your channels to your pulmonary system, isn't it? So issues with your pulmonary system are going to affect your right ventricles. Issues with your systemic things like your hypertension or any other systemic pathology can lead to effect of left ventricles, right? So that's a simple logic we have here. So long-standing hypertension increases cardiac overload and promotes left ventricular hypertrophy, whereas pulmonary hypertension and certain lung diseases such as emphysema may lead to right ventricular hypertrophy. So you can just make a note of these points as well. Yeah. And coarctation of aorta is nothing but narrowing of aorta, which can lead to systemic hypertension, again left ventricular failure, aortic dissection, ischemic heart disease, and cerebrovascular accidents, right? So I advise you to make a note of these points as well. So the incorrect statement is option B, that is long-standing hypertension leads to right ventricular hypertrophy. So long-standing hypertension promotes left ventricular hypertrophy. Issues with your pulmonary system might lead to your right ventricular hypertrophy, and the coarctation of aorta can lead to systemic hypertension, left ventricular hypertrophy, ischemic heart disease, and cerebrovascular accidents. It's option D. Okay, now let's move to the next one. Which of the following is false with regards to ultrasonography? Interpretation is only possible during examination. No radiation, not good for soft tissues, inexpensive. So which of the following is an incorrect statement again pertaining to ultrasonography? Some of the complications pertaining to the previous question, right? Yeah. So obviously, good. Obviously, ultrasounds are for soft tissue imaging, isn't it? And they are inexpensive, no radiation, and real-time observation of what's happening inside, isn't it? So we use high-frequency sound waves based on the Doppler principle, isn't it? So ultrasonic imaging, also called ultrasound scanning or sonography, is a non-invasive, non-ionizing, inexpensive, quick imaging modality. Real-time images can be seen, right? Yeah. So option C is the right answer. Good. Now let's move on to the next question. Velcro crackles are heard in lung cancer, pneumothorax, pulmonary fibrosis, pleural effusion. Velcro crackles. So what are Velcro crackles and where do you see them? You might have heard of the term crepitations or rails in your general medicine, isn't it? So they're nothing but the popping up a sound because of especially air spaces when they are filled up with fluid in case of emphysema. So popping up a kind of sound, these are nothing but your crepitations or crackles or rails. We have different names depending upon the country. In UK, we call them as crepitations. The term crepitations is used. In US, the term rails, RALs, rails is used. So popping open of small airways and alveolar collapse by fluid exudates or lack of aeration due to during expiration. Yes. So crackles can be heard in patients with pneumonia, pulmonary fibrosis, acute bronchitis, pulmonary edema, post-thoracotomy, left-sided congestive heart failure. So you have various conditions where you can see these crackles. Chronic pulmonary fibrosis sometimes produces a distinct type of low-pitched crackle, which is called as Velcro crackle. Velcro is nothing but in sphygmomanometer you have the area where you will try to fasten your belt with to your arm. So you have that mesh. So on opening that mesh or on closing that mesh, you will have one characteristic sound, Velcro mesh. So hence this crepitation is called as a Velcro crackle. So chronic pulmonary fibrosis sometimes produces a distinct type of low-pitched crackle called Velcro crackle, similar to the coarse sound made by the Velcro mesh, which we use while checking your blood pressure. You have your sphygmomanometer and you have a belt-like structure which you fasten to your arm. So on opening up, you get a characteristic sound, isn't it? Or maybe Velcro is nothing but, or to simplify it, you have your mesh which is placed alongside your windows to prevent mosquitoes from coming, right? So that's your Velcro mesh. Yeah. So chronic pulmonary fibrosis produces a distinct type of low-pitched crackle, Velcro crackle or Velcro rail, similar to the coarse sound made by the Velcro mesh, which is present in your sphygmomanometer, right? Yes. So Velcro crackles are heard in case of your pulmonary fibrosis. Chronic pulmonary fibrosis. So these crackles are also called as crepitations or rails. So we have a few other conditions where these crackles can be heard. Pneumonia, pulmonary fibrosis as we discussed now, acute bronchitis, bronchiectasis, pulmonary edema secondary to left-sided congestive heart failure, and also intestinal lung disease, interstitial lung disease, okay? So it's always better to make a note of these points so that you can have them in your memory and you can simultaneously revise just before exam, which doesn't take much time, right? Okay, now I think we are in our penultimate question. Yes, ninth question. Commonest site of vermiform appendix is retrocecal, subcecal, preiliac, preilial, postileal. So, which is the commonest site of vermiform appendix? So, vermiform appendix is a vestigial organ. It contains a epithelial band of lymphocytes, which is known to play a role in the defense in the intestinal region, right? So, immunological defense against microbes in digestive tract. So, it has that role. So, it's commonly susceptible for inflammation. So, we have this emergency procedure, right? We call this as 24-hour pain. So, commonest site of vermiform appendix is. So, sites of appendix, we have different sites as given in the options: retrocecal, subcecal, preilial, postileal, and also pelvic. Just make a note. Retrocecal, commonest site, retrocecal in 74% of the cases, and pelvic, it's around 21% of the cases. So this appendix is considered to be a vestigial organ. It has this propensity for information, so commonly we go for removal of this vestigial organ in cases where there is inflammation. And it's also considered this appendix is considered to be an abdominal tonsil. You can just add up that point, right? So appendix is considered as an abdominal tonsil because its submucosal contains lymphatic aggregation, so it has a role in defense against microbes in the digestive tract. Okay. Yes. The last question. Test used for Dibbin-Johnson syndrome. Gamma glutamyl serum amylase, bromosulfaline test, hippuric acid test. So what is the test used for Dibbin-Johnson syndrome? So Dibbin-Johnson syndrome is an autosomal recessive defect where there is a defective hepatic excretory function. So the cells are unable to excrete this bile. It's mainly because of defect in the enzyme. The name of the enzyme is multi-drug resistance protein 2. The enzyme multi-drug resistance protein 2 is defective. As a result, hepatic excretory function is altered, and this enzyme which I mentioned, multi-drug resistance protein 2, is essential for excretion of bilirubin, right? So there is a defect in this enzyme. As a result, when you go for this bromosulfaline test, the appearance of the initially the moment you give this compound, it doesn't appear in the plasma, but the appearance of late rise in plasma levels of bromosulfaline is the characteristic sign of Dibbin-Johnson syndrome. So it's mentioned that biliary excretion of number of anionic compounds is compromised. So just like your bile, so what happens in this Dibbin-Johnson syndrome is that the hepatic excretory function is being compromised because of the defect in the enzyme multi-drug resistance protein 2. As a result, various anionic compounds are not excreted effectively, right? So what happens is this bromosulfaline is also an anionic compound. So even this, the clearance of this compound is also compromised. So biliary excretion of number of anionic compounds is compromised, including bromosulfaline, to test for Dibbin-Johnson syndrome. The role of disappearance of bromosulfaline from plasma is determined, and patient with Dibbin-Johnson syndrome, this is very important. Patients with Dibbin-Johnson syndrome exhibit a characteristic rise in the plasma concentration of this drug after 90 minutes after injecting due to reflex of conjugated bromosulfaline into circulation from hepatocytes. Yes. So yeah, the previous question is pulmonary fibrosis. We haven't mentioned that here. You can check out here for any velcro crackles in pulmonary fibrosis. Yeah. So Dibbin-Johnson syndrome is a condition where there is defective excretion, hepatic excretion of bile, not just bile, anionic compounds as such. So including this bromosulfaline, when you give, it's not effectively excreted. But it's mentioned that at 90 minutes, around 90 minutes, there is characteristic rise in the levels of bromosulfaline in plasma, which is a characteristic feature of Dibbin-Johnson syndrome. So initially when you give this compound, it's absorbed by the body, but because of the problem or the issues with the excretion, so what happens is the hepatocytes fail to excrete this compound into bile. So as a result, what happens is the compound remains in the plasma, and you can see the rise in the plasma levels approximately after 90 minutes. Fine. So general medicine altogether, we need to go through different concepts, and we'll definitely focus on general medicine as well this week, and we'll discuss few more additional points pertaining to general medicine today as well as tomorrow. Yes, you're welcome, Shilpa. So I'll make sure that I'll take a pic and I'll share it in our group. And if you have any further questions, you can drop a mail at talktobidentist@gmail.com, right? Yeah. So see you again today evening at 8 p.m. Bye. Have a nice day.